see.
Okay.
All right. We are live. Let me just check. Oh, I've got 3 check marks. All right.
Yes, it
Yay.
says recording started. So
Okay, awesome. All right. Hello, hello. Good afternoon. Happy Friday, everybody. I am very excited for our conversation today. I have Dr. Cheruba Prabakar, who is a minimally invasive gynecologic surgeon and the owner of La Marinda Gynecology and Surgery. And we're going to talk about endometriosis today. So, welcome, Dr. Prabakar. Tell us just a little bit about yourself, and then we can get into it.
yeah, thank you so much for having me. As I was just introduced, I'm Dr. Prabakar. I'm an OBGYN and a minimally invasive surgeon. I live in the San Francisco Bay Area, and I'm the founder and CEO of my own private practice. And in this practice, I really focus a lot on surgical gynecology. And the two things I see the most are fibroids and endometriosis. And two of the most least, I would say, two of the least talked about topics in gynecology, and arguably some of the most important. And so I'm really excited to be having this conversation, bringing more light to endometriosis and really validating the experience of so many women who are suffering from this disease. So I'm excited to be
Yes.
here.
Yes, awesome, for sure. And thanks for joining me. Probably some people might ask, like, why is a colorectal surgeon having this conversation? And we'll get into that. But before we do, you have some news for everybody. And I'm going to let you go ahead and tell us what that exciting news is.
Yes. So I am releasing my first book next month. It is
Woo!
called, yes, woohoo. It is going to be so good and so impactful. And it's titled, I wish I had a physical copy, but I don't have it yet from the publisher, but it's called Fibroids Finally Heard. And it is a guide, it's a practical guide for patients from diagnosis to recovery. And this is a much needed playbook for women out there who are suffering from fibroids. And there's really nothing that exists out there right now. And 80% of women will be diagnosed with a fibroid by the time they're 50, and 90% of women of color. And so this is a huge problem, huge problem.
Yeah.
And so I'm really excited to get this book into the hands of many, many women. And so, yes, we'll put the link below once that comes out. And it's going to be released July 15th for Fibroid Awareness Month. And so check it out. And I talk a little bit there about endometriosis as well, because 40% of the time, these disease states coexist together. And so a lot of times when I'm operating for fibroids, I actually see endometriosis. So so this is a very timely discussion.
Yeah, they definitely go hand in hand. I mean, I know nothing about fibroids and the treatment of it, but what I do know is I have a lot of friends, mostly women of color, that suffer with it. And, we were kind of brought up to be like, yeah, they just kind of have hard periods, and we'll get into that too. But, truly it's a disease process that needs definitely more attention. So this is very exciting. I'm excited to read it myself. And yeah, happy to promote it once it comes out again. So
Thank you.
all right, so let's get into it. So, you are a minimally invasive gynecologic surgeon, which means that you did additional training after OBGYN residency in essentially how to do complex pelvic surgery using minimally invasive techniques like laparoscopy and the robot. Is that
E-
correct?
Exactly. I think when we come out of residency, OBGYNs spend a lot of time delivering babies, which is the OB part, and a lot of time also doing GYN. But to really get proficient at the many tools we have right now, right? Surgery has evolved so much from just open surgery to now robotic surgery and laparoscopic surgery. It really took me another couple of years to get very, very, proficient at that and do the number of cases that's required to be good.
Yeah. And one of you kind of already mentioned it, but two of the major things that MIGS, for short, surgeons deal with are fibroids and endometriosis. So, one of the things I wanted to talk about is why does it take so long to diagnose endometriosis? Let's just start there.
Yes. So we know that it takes an average of 7 years before endometriosis even diagnosed, and this is really unacceptable. But endometriosis, in short, presents very frequently with painful periods, sometimes irregular bleeding, sometimes spotting in between your periods, nausea, all these things. But for a long time, women and young girls were just told, well, that's just part of being a woman, or this is just part of having your period. And so women have been dismissed over and over again that, well, this is like, suck it up. Like, this is just like part of, part of the whole process. And so a lot of women have just kind of internalized that message. I mean, I hear it even now in women in their 30s and 40s. They'll
Yeah.
apologize for coming in and
Yeah.
complaining about their periods. And I'm like, well, this is not normal, you know? And then, we have a cultural perspective as well. There are some families where this kind of thing is not talked about, some cultures where it's like hush
Mhm.
hush, well, like just kind of like deal with it behind closed doors kind of thing.
Yeah.
So this is, I think, why it takes so long to actually get a diagnosis.
Yeah. And kind of to your point, like I'm thinking about some of the women that I have seen when I collaborate with the MIG surgeons. They come in and they're almost like over explaining their pain. And it's very clear to me that they have explained this once before. And multiple people have told them what you just said, like, this is just what it is, or you just have bad periods, or suck it up. And I just literally stop and I'm like, not to interrupt you, but I believe you. And then they're just like that's like half the battle right there, just being like, I believe you.
Yes.
And so a lot of them have been on anti-anxiety meds, antidepressants. They've been on like a slew of all these IBS medications. And like you said, they just internalize like, yep, I just have bad periods and suck it up kind of thing.
Yeah.
And that's awful. That's awful, being
It's
by the healthcare system.
totally. And it takes time to really dig into all these symptoms and get a good history from patients. And as you know, our healthcare system is so broken, appointments are like 15 to 20 minutes long. So before
Right.
the patient gets their blood pressure and their height and weight taken, you have 10 minutes
Right.
to kind of listen to their story and hear it and put it all together. And so it can be very, very challenging. And endometriosis can also be sneaky in the way it presents, right?
Yeah.
Like, it's
Yeah.
not always the classic painful periods, but
Right.
sometimes it can present in different organ systems. And so you really have to put in the time to ask the patient all these questions. And so I think this is why it often just gets missed.
Yeah. You said the word sneaky. I have like a more like expletive version of how I describe endometriosis, but we have named this in the spirit of the World Cup. Haiti is playing tonight. My
Yes,
father's from
yes.
Haiti. It's
Let's
their
just,
first time in the World Cup in 52 years. USA is playing right now and winning. It's a fun time, but we have used the spirit of the World Cup to title this, red card. What is it? Why endometriosis plays dirty. So
mhm.
talking about it being sneaky, in addition to not being heard by providers, imaging studies, there's no real imaging study or blood marker for this too. Can you elaborate a little bit more on your experience with that?
Yeah. So many times when patients tell me their story, I'm like, oh, this really seems like endometriosis. But then they'll show me their ultrasound, they'll show me a pelvic MRI, and they'll say, well, I just got all this imaging and it's not there. Like, there's no sign of endometriosis. Um, but I will still push to do a laparoscopy. And sure enough, 9 out of 10 times, I will see endometriosis. And so I wish, like, yes, we have the most amazing technology today, but it's not sensitive enough to pick up the stage one or stage two, or sometimes even stage three.
Yeah.
Um, and when I go in for fibroid surgery, the MRI will say nothing about endometriosis, but many times I'll see at least stage two endometriosis. And so our technology is good, but it's not that good. I think the patient story and the kind of like the evolution of symptoms over time is our best guide. And so, like we learned in medical school, like a good history and physical will often give you the diagnosis. So
Yes.
it's dirty, and it plays dirty because it doesn't show itself, and you kind of have to like be a detective sometimes
Right.
to put it together.
Yeah. And you made a good point earlier when like you're in a system where you're pressured to see patients every 15 minutes. You don't have the time to get that whole history. So you and I have done it a little bit differently with our practices. Thankfully, we get to spend as much time as we want with patients. But this is honestly a history and physical type of diagnosis, right? You just have to have a high index of suspicion where you hear these things and then trouble getting pregnant. And then you're like, your mom had the same thing, or, and it's like, oh, this sounds like endometriosis. And it doesn't matter that all these studies are negative. And all the negative studies add to the gaslighting that they experience, where it's like, well, it's
Yeah.
saying nothing's wrong with me. And so that's why it gets a red card. It is very, 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 very
Yes.
sneaky. Um,
Yes.
kind of moving into it being a multidisciplinary disease process. Obviously, as the gynecologists, especially the minimally invasive surgeons, you guys kind of bear the biggest diagnostic and treatment burden for helping to take care of these patients. But I have been very privileged to get involved in these patients' care, and it's been incredibly gratifying, to be honest. And it's definitely my niche and my passion now, getting to work with you guys to take care of it. But tell me about some of the other, like, maybe non-gynecologic symptoms that patients will come to you that like raise a red flag, maybe related to the GI tract, or why a colorectal surgeon or some other type of surgeon would get involved.
Yeah. So I just had a patient this morning who told me that the day before her period, she'll get these sharp pains in her rectum. And
Mhm.
then, her period will come after a day or so, it gets better. Then the whole month goes by. Next month, the day before period, again, sharp pains in her rectum. And that's literally how she knows she's about to get her period. I mean, it's mostly on time, but that's kind of her clue. So that's something that I hear. I also hear that right before somebody gets their period, they have bright red bleeding, from rectal, essentially the rectal bleeding. And every single month this happens, and it's not bleeding any other time, but it's right during the
Mhm.
period. So these were some of the top two that I would say that lead to me suspecting clearly there's some, GI involvement here. Other things, these are more rare, but I have seen a patient who said that, oh, I'm extremely short of breath during my period. And she was one of those patients who had, endometriosis, like in her lung tissue,
Yeah,
um,
that's
or even
crazy.
in the diaphragm, right?
Yeah.
So we see those. I've also heard of cardiac endometriosis, although
Wow.
I haven't seen a case of that, but I've read about it.
Mm.
We had a patient with endometriosis in her belly button. Um, which, from previous laparoscopic surgery,
Yeah.
there was like a little seed of endometriosis that came out through one of the, one of our instruments or trocars, and then she had endometriosis there. I've seen vulvar endometriosis. Um,
Oh,
yeah, where someone's like, oh, I have this like bump and it gets big every time I get my period, which can be a little non-specific, could be multiple things. But
yeah,
when we finally took it out, yep, that was endometriosis. And so it's not always the classic, well, I just have pain with my periods, or I have painful
yeah,
sex,
yeah,
or painful bowel movements. You sort of have to think about endometriosis like, everywhere. And again, asking more questions and really trying to dial it down into like, is it related to your period in any way? But
yeah.
it's been kind of fascinating to see.
Absolutely. And again, red card. Why is endometriosis in the chest? Um,
Right, exactly. Deserves to be out of the game.
right, exactly, and not in the next game either.
Yes.
Um, and then a quick thing, just the definition of endometriosis. When I initially was kind of learning about that, we didn't really learn about it in residency, but when I was kind of learning about it, I always thought it was ectopic endometrial tissue, but it's more ectopic endometrial like tissue. So it's not exactly the endometrial lining that is outside. It's tissue that acts like the endometrium, right? Outside.
Well, I
The
think there's different theories still as to
Yeah.
what how endometriosis like actually happens, right? Like how
Mm,
does it get out? Like what is it? But there is some the main theory still is that it is like lining of the endometrium that goes backwards to the fallopian tubes and implants. Um, and if it starts to bury itself in the wall of the uterus, then it's called adenomyosis. And
mhm.
sometimes you have both together, sometimes you have one. But there's different theories like, does it go through the lymphatic system, and spread? Does it go through the fallopian tubes and spread? Is it de novo, just tissue that kind of forms in different
Yeah.
parts of the body too, which then would not be endometrial tissue, but a
Right.
different type of tissue that behaves like the endometrium? So I think part of it is also we don't really have, the exact answers,
Yeah.
and more research is still needed.
Yeah. And I read a study that showed that they found endometrial like tissue or endometriomas in fetuses. So it's not necessarily just women who have already gone through their first
Yeah.
period, menarche, or anything like that. So yeah, there's still a lot that we need to learn about it. And then
Yes.
talk to me a little before we get into the surgical part. Talk to me a little bit about the metabolic and hormonal behaviors of endometriosis and sort of why it happens during our period that those implants give us those bad symptoms.
Yeah. So these implants of endometriosis are stimulated by our hormones, specifically estrogen. And so during our cycles, it's just not the lining of the uterus that's stimulated, but it's wherever this endometrial tissue or endometrial-like tissue is scattered. It could be on your ureter, it could be in the rectum, it could be, your diaphragm, wherever it is. The hormonal stimulation happens throughout. And so this is why women often have this diffuse kind of pain
Mhm.
or a very specific pain depending on where this tissue is. So and a lot of our treatments are aimed at blocking this stimulation.
Yeah. Can you give an
Yeah.
example of a couple of like, so let's say you have somebody that's maybe not ready for surgery, doesn't want surgery, they want to try medical management. What's
Mhm.
the algorithm that you use before they get to me? They've already tried everything else with you
Yeah.
guys. So what do you
Yeah.
guys generally prescribe for these
What do we
folks?
do? So
Yeah.
you can start with something as simple as a birth control pill,
Mhm.
either a progesterone only birth control pill, which I usually prefer, a pill that does not have estrogen. And we have a couple of good ones. So that actually helps really regulate the hormonal environment and prevents kind of this real up and down as we would with our natural cycles. So it sort of artificially controls the environment and helps women with endometriosis. So that's kind of an easy one. And it's a pill. You can, if it doesn't work out, you can just stop it.
Yeah.
We also have combined birth control pills with estrogen and progesterone. And this is a little bit more. There's more trial and error because estrogen stimulates endometriosis. So it's like, should
Yeah.
you really be giving somebody estrogen? But for some people, it really, works well. Then we have more advanced medications like myfembree, which decreases pain with endometriosis, and it also works well for those who bleed from fibroids. So it's kind of
Mhm.
a two-in-one, at least in my office. You can also use other suppressants like Lupron. They've a little bit fallen out of favor because it's an injection, and once you get it in, it has to stay there for a month or 3 months. So a
Yeah.
lot of people are not a big fan of that.
Yeah.
So that's good. And then IUDs can also help with pain and the irregular bleeding. While it may not, completely take away your endometriotic lesions, it can help you with symptoms. So these are some of the quicker things that we try in the office prior to going to the OR. But I do want to say that surgery is the gold standard for diagnosis.
Right.
A lot of women will say, well, I think I definitely have endometriosis. Like, I'll do all this, and they'll put in the medical chart they have endometriosis. But I'm like, well, like, unless we really get in there and take a look, like, we can't really confirm. Yeah,
Right.
and hopefully we'll have better options for that in the future too, without having to be so invasive.
Yes, for sure. Okay, so then we've tried all the medical things, and then they're like, "Okay, it's time. I need surgery." How do you counsel them, and then how do you know when you need to get another specialist involved to do combination surgery with you?
Yeah, so we always definitely get an MRI, which is the best we have right now in terms of letting us know, like, is the rectum, stuck onto the uterus,
Mhm.
are the ovaries stuck to each other, like, what's really happening. And you can tell some of this through exam and, again, history, but the
Mhm.
MRI is really great. And if we do see that there is colonic involvement, like the colon is stuck somewhere onto the uterus, which is stuck to the abdominal wall, or the rectum is stuck, then we let our colorectal surgeons know ahead of time, like, hey, I'm operating, in this case. Sometimes we'll have them see the patient as well, especially if we are pretty sure they need to come in and
Mm,
do some dissection or resect. Endometriosis will do make sure they have a consult with the patient, and then we'll start and then call them as needed.
yeah.
Yeah.
And just to kind of talk about the multidisciplinary aspect of it. So like I said, I've had the privilege of getting to treat a lot of these patients, and a lot of the symptoms the most common symptom I've heard from like a GI standpoint are severe bloating. They get horrible bloating. They get that
Hmm.
pain with defecate, like a sharp pain when they have to have a bowel movement, and then also severe constipation. So those
Mm.
are three major symptoms and so I've seen patients for chronic constipation, and then I ask deeper questions, and I'm like, that sounds like endometriosis. And so I'll get the MRI and send them to the gynecologist to be like, hey, can you, see this patient and rule it out. But if I get sent the patient from a MIGS surgeon, um, that's usually the story. It's the story of
Mm.
painful periods. It's the story of being, undiagnosed for 10 years. It's the story of, everything that we've already said.
Yeah.
Um, and usually when I really like seeing them preoperatively because I don't like being
Yep.
surprised in the operating room.
Yep. Yep.
And I very much enjoy seeing and taking care of these patients, but I always have them do a full bowel prep, meaning cleaning out all the stool from their colon, because like you said, the MRI doesn't tell us the full story. You don't know the full
Hmm.
story till your eyeballs are inside of that person's belly. And sometimes it's just an adhesion tenting it up to the uterus. And that takes nothing for me but great that I'm there, but it takes very little for me to actually mobilize it. And sometimes that's enough for their GI symptoms to go away. And then sometimes those endometriomas are primarily inside the wall of the colon. They're not even attached to the uterus. They're like predominantly or all the way inside the wall of the colon. So I'll do like a full thickness, like I'll core it out. So the rule is if it's less than 3 centimeters and less than 50% of the circumference, I can just kind of core it out full thickness and then sew up the colon. But if it's more than that, if I attempt to core it out, I'll destroy that piece of intestine. And so we just do a resection. And, I counsel people for the most part, it's usually the proximal rectum. So higher up in the pelvis. And so the likelihood of people needing an ostomy bag is very, 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 very low, unless they have other features that don't make it safe to put the intestine back
Hmm.
together. Uncontrolled diabetes, smoker, previous radiation, which almost none of these women have.
Hmm. Yeah.
Um, but if it's a very, very, very low endometrioma where the anastomosis, that new connection is very low in the pelvis, oftentimes I'll do something to protect that. But by and large, most people do not need a resection. And it seems like their symptoms, particularly that sharp pain with defecation, go away as soon as you
Yeah.
immobilize it off of the uterus. And to be able to do that for what feels like, I don't want to say not that much work, like to be able to do that, and then you have somebody and they're like their symptoms are way better. Like, what is more gratifying than that? To be able
Right.
to help somebody who has been dismissed, not listened to, you tell them I believe you, and then you go in and you do the surgery and you get to do it with a team. Like, that part's super fun for me too as a solo private practice
Hmm.
surgeon. Like, I never get to operate with people, so that part's really fun, and then they get better and you're like, who wouldn't do this?
Yeah.
So it
And
it yeah.
going back to your point about constipation and bloating, I mean, so many people just get told, well, you have IBS.
Yes.
Like that's the
Yes.
other common thing that people come in with. And I'm like, are you sure this is IBS? I'm like,
Yeah.
this sounds more like endometriosis.
Yeah.
Like you said, but the more you have to ask more questions, you can't just say,
Yeah.
oh, okay, you have constipation and bloating. Okay, well,
Yeah.
yeah, that could be IBS or it could be something else.
Yeah.
So that's another commonly kind of glossed over
Exactly.
set of symptoms.
And IBS is sort of a diagnosis of exclusion. Of course, it exists, and of course, there are people that benefit from the medications. But I'm not seeing those people in my office, right?
Yeah.
They've gotten better, but the people that are on every single type of, the Motegrity, the Linzess, the
Mm,
all of those medications, and nothing's working, and they're having painful periods. It's kind of like that light bulb has to go off. So.
yes.
Um, all right, so let's talk about something else. All right, so um, for patients that are watching, what are the red flags they shouldn't ignore, and when should they ask for a referral to a specialist?
Yep. So when we talk about periods in general, I just want everybody to understand that you may have a little cramping, you may have a little discomfort, but your periods really shouldn't take you out. Like
Mhm.
that is just I don't care, what your grandmother did and what your mom did, but that is not normal. That is not normal. And I think that is the first thing I just want everybody to understand. Sure, are we going to get some cramps and we take a Motrin here and there? Yes, it's not the most comfortable thing, but you should still be able to go to work, go to school. I mean, my youngest patient is 10 years old, right? Like that is
Mm,
just so. I mean, she had to like pull out of school and get homeschooled because
yeah,
she couldn't even make it. And it wasn't just during a period; it was like the whole month.
yeah,
And so, if you're starting to have symptoms like that, that is not normal, and you should see a gynecologist or a specialist ASAP,
yeah,
because the more information you gather, the better, and then you can actually track your symptoms and say, yeah, is this actually getting worse? So number one, just don't ignore painful periods. That's not normal.
right. Don't
And
accept that's just how your periods
e-
are. Yeah.
exactly, don't accept that. And your periods should be a non-event. As I was just doing an IG live with Dr. Shirazian from New York
Mm.
with fibroids, and we were talking about how, yeah, your period should really just be a non-event. It may be a little
Yeah.
uncomfortable, but
It should be
life
an
has to go.
annoyance, not right.
Yes, exactly. It's an annoyance, but life can still go on. You shouldn't have to
Right.
cancel all your plans because of
Right.
it. Right. And then number two, I would really just track symptoms. I think that's something that many now we have all these apps and all these fancy things, and you don't even need all that. You can just literally write it down and see, does it correlate to your periods? That's kind of a giveaway. Like when I ask patients these questions like, hey, is it around your period? And they're like, oh, I really haven't paid attention to that. Well, keep track of it, because the more information you bring to your doctor's visit, the quicker, we can move on with the diagnosis and like
Yeah.
treatment, right?
Yeah.
So those are the two things that I would kind of say to everyone watching, like, think about those two things.
Yeah. And then also for the patient watching, a lot of times I get asked, what do the incisions look like? How long is the recovery after endometriosis surgery? Do I have to stay in the hospital for a long time? What's the spiel you give your patients?
I mean, most of our patients go home the same day. Even if we're doing a hysterectomy for
Mhm.
endometriosis, you still go home the same day. And the first 24 hours are not hot. Like, I mean,
Mhm.
you're gonna nauseous from the anesthesia and everything, so you don't feel great. But after that, the next day you should be walking around and starting to eat. And within a couple weeks, most of my patients are driving and kind of back to doing things. In terms of heavy lifting and going to the gym, I would say wait a little bit more or get cleared at that 2 week mark.
Mhm.
um, but and of course it depends what type of surgery you have for endometriosis. Are you getting just like a kind of clean out and biopsies, or are you getting a hysterectomy, or are you getting bowel surgery, right? It will depend on what it is, but regardless of specialty, we almost always do these minimally invasive, and so
Mhm.
you can go home quickly.
Yeah, that part has been really awesome. And I feel like not every patient, but we've had some patients where like it's sort of like they trade one pain for the other, like the incisional pain, but they know the incisional pain will go away, but this other pain is like gone almost like immediately within the week. So that part
Yes.
also, as a surgeon, we like instant gratification. Like that part
Yes.
is extremely gratifying
Yes.
as well.
Yes. Patients will say, I that pain went away in the recovery room. Like, you
It's
know what I mean? Like
crazy.
that is the best. Yeah.
It's crazy. It's amazing. Okay. And then how about like what does it look like getting your life back after treatment? Like when you see these patients a few weeks, a couple months, whatever, post-op, like what do they look like? What do they feel like?
I mean, this pain, like I said, a lot of them will say, like, oh, within the first 24 hours in the recovery room, like this pain went away. And many of them don't even know what it feels like to live a life without constant pain, so they're kind of getting used to a new normal.
Mm,
Um, and I will also say, though, not every
I was just
patient
gonna say that. Yeah.
who has endometriosis surgery is like, oh, I'm a brand new person.
Mm,
Yes, their pain may be better, um, but it's not always 100%. Sometimes
mhm,
we have to do a second surgery. Sometimes the endometriosis has affected like nerves, and it's not just like what we see. And so I always counsel patients, like, your pain will likely get better, but it's not guaranteed and
Mhm.
it may not be 100%. So, but there's usually some improvement in the whole continuum of their symptoms that they've been feeling. There's almost always improvement.
Right. And for
Yeah.
those patients that keep their ovaries, which, we obviously want to try to keep ovaries as long as we possibly can in patients. Um, how do you counsel them? Because with the persistent estrogen, which is what we want, the benefits of the estrogen, it's
Yeah.
possible for it to recur. So how do you talk to them about that?
Yeah, I mean, even in patients who I do a hysterectomy, I'll say, well, the organ that has the lining and all of that is gone. But if you do have implants elsewhere, that we will resect. But if you have your ovary still, that you're still having estrogen stimulation of microscopic endometriosis, that
Mhm.
is implants around your pelvis. But I will say that if they're under 50, that's usually when I will say, like, okay, you should consider keeping your ovaries, because that's what the study show. It shows that
Right,
above 50, then you consider removing it and just putting them on hormone replacement therapy.
right.
And so I find that most patients do want to preserve their uterus. If they're under like 55, most of them just want to keep, and not the uterus, the ovaries. And
Mhm.
so I think that's totally reasonable. And I have not, like, recently had to go back a second time just because, just to take out their ovaries.
Right.
Just removing endo and removing the uterus often has been enough.
Awesome. Awesome. Um, okay. So one thing you want every person watching to walk away knowing about endometriosis.
So endometriosis can be sneaky. As I said before, it can be sneaky. It can disguise itself as many other things, including the most common ones: bloating, constipation. The other symptoms that we diagnose are pretty classic, so everybody thinks of endometriosis when we say those things. But a vulvar mass, or an umbilical mass, or the GI side effects, or shortness of breath. These things can pop up with endo, although rarer than the classic pain with sex, or pain with bowel movements, or pain with periods. And you know your body. And so trust it.
Yeah.
And if something doesn't feel normal, seek help until you get the answers. I think
Right.
that's the most important thing. There are doctors out there are surgeons out there are, it sounds so discouraging, and sometimes it is, because it seems like you can never find anybody, or the wait list is 6 months or 8 months. But we are out there. There are doctors who will listen, and so don't gaslight yourself and say, oh, well, this must be true, or it must be in my
Right.
head. I've literally had patients tell me that, I think it's in my head. I'm like, no,
Yeah.
it's not.
You're like, no, it's in your pelvis,
It's in
actually.
your pelvis,
Yeah.
yes. And so trust yourself.
Yeah. And we didn't even touch on the infertility part. That's like, we could do that a whole nother time, but, focusing on mostly pain and quality of life. But, the infertility part also is very important to a lot of patients that are struggling to conceive. Um,
Yeah.
and I know you get involved with a lot of those patients as well. But
Yes.
to wrap up, I want to talk one last time. Tell us about your book, when it's coming
Yes.
out, what it's called, where we'll be able to get it.
Perfect. Yes. So you can sign up on my email list at thefibroiddoc.com, and you'll be one of the first to know exactly when it drops. But the plan is July 15th, 2026, which is just next month. And it's called Fibroids Finally Heard: A Patient's
Okay.
Guide from Diagnosis to Recovery. And we talk about endometriosis there. And a lot of the things we've just talked about will resonate with you when you read the book, because these two disease states are very similar. And so, yeah, I would love for you guys to read it, gift it to somebody that you think has endo, has fibroids. And yeah, my goal is to reach as many women as possible.
That's amazing. And this book is appropriate both for clinicians, for doctors, and for patients and family members of those who might be
Y-
struggling with fibroid
yes.
endometriosis.
Yes, it is not an academic book in that, like, yeah, you don't need to be a doctor to read it. It's anybody can pick it up, and it's a quick read, 2 hours, 2.5 hours.
Amazing. Amazing. And then last thing, where can we find you? Tell us where your practice is, what the name is, and then social media where we can find you.
Yes, so I am in the Bay Area in California. So if you're anywhere in California, we could do a virtual visit. I'm in the San Francisco Bay Area, and you can find me at the Fibroid Doc across all platforms: Instagram, TikTok, YouTube. And you can also schedule a coaching call with me if you're somewhere not in California, anywhere else in the country or the world, and you just want someone to listen to your symptoms and just kind of help you think through things before you see your doctor. We're happy to do that in our practice as well.
Amazing, amazing. It is so good to talk to you. I'm so happy that our paths crossed, what was it, like 2 years ago? And that now
Yes.
professionally our paths are crossing as well, even though we're in two different places. Maybe someday
Yes.
we'll get to operate together. That would be amazing.
Yes. That'd be great.
All right. Thank you for anybody who was paying attention or watching. If you guys have any questions, you can hit up Dr. Cheruba Prabakar on any of her socials or send questions to mine, Ritha Belizaire,
Yes.
MD. And we should do this again. We'll figure out another topic we can talk about.
We should do this again, and let's just show off our shirts. Go
Oh, yeah.
USA, right? World Cup.
Go Haiti, Anale.
Yes.
All right. Have a good
All
one.
right. We'll see you. Okay. Bye. Bye.